Hi, everyone. I'm pleased to welcome three very special guests. Joining us today are three NET surgeons from across the United States who will address some common questions and concerns that often come up in the patient community. Today, we will not get into the details of various types of surgery, which is information you can find on our YouTube channel from past presentations. Instead, we hope this conversation with three NET surgeons will show you how they think about and discuss some common big picture issues to inform you as you prepare to meet with your surgeon. So joining us today are Dr. Daniel Anaya, surgical oncologist from Moffitt Cancer Center in Tampa, Florida, Dr. Callisia Clarke, surgical oncologist from Medical College of Wisconsin in Milwaukee, Wisconsin, and Dr. Alexandra Gangi, surgical oncologist from Cedars-Sinai Medical Center in Los Angeles, California. So we're going to start with the first question, which is a big one. Dr. Clarke, how do you determine if a patient is a surgical candidate, and what is the best surgical approach?
So I think determine whether or not a patient is a surgical candidate is quite a nuanced conversation. I think it usually starts with the initial visit that you have with the patient. And usually at that time, I go in detail over labs, lab values, and any imaging, cross-sectional imaging that we have that gives me an idea of how much disease they have and where that disease is located. Other aspects of their cancer that really impacts whether or not they can undergo surgery or should undergo surgery include the grade of the disease, the location of the disease, and the extent of the disease. I'll also make a caveat of saying that usually the decision for surgical resection shouldn't be made in isolation by just a surgeon. Typically, I would consult with my other colleagues, which include interventional radiology, medical oncology, as well, so that they can all weigh in. But ultimately, the decision to proceed with surgery really should be based on what we think is going to extend life or possibly cure if we can, and certainly allows us to reserve other treatment options for the patient down the line should their disease recur. The surgical approach is also quite varied depending on the tumor and the actual patient. The techniques that we use take into account removing all or most of the cancer that's present while making sure that we do everything we can to preserve the quality of life for the patients and minimize toxicity from surgery and sort of long-term complications that can impact day-to-day living. But those are some of the things that I keep in the back of my mind as I have these discussions.
Thank you. It's a holistic and a big discussion here. Dr.
Absolutely.
Gangi, what would you have to add to this?
I think Dr. Clarke has hit the nail on the head. Candidacy for surgery is not a thing that we select independently, but obviously it's the overall health of the patient and the specific tumor type that we're treating, the extent of the disease, the grade, what other therapies the patient's had. So certainly it's a multidisciplinary decision, but we do look at all of those components.
Yeah. Dr. Anaya, what about you?
I think my colleagues have really kind of emphasized all the critical aspects. I think, it's really more about understanding, particularly with neuroendocrine tumors, that there's a lot of different type of treatments. Really understanding how surgery is going to help these patients. Is it going to help them by increasing survival, like Dr. Clarke said, or by palliating symptoms, by giving a shot at getting cured? And how is that in comparison to other treatment approaches?
That's helpful. What is the goal of the surgery? Let's go to the next question. Dr. Gangi, patients are sometimes told that they're not a surgical candidate. What are your thoughts about this? For example, can surgery be done for tumors in the peritoneum or mesentery?
Yeah, so I think that's a good question, a challenging one, because I think there's two separate components there that you want to look at. One, sometimes patients are told they're not a surgical candidate because they may have other comorbidities precluding them from being able to tolerate an operation. So in the broadest sense, I think we always worry if a patient can tolerate what we're going to do to them because maybe they have a bad heart or bad lungs, and it might be too dangerous for them to have anesthesia or something along those lines. So in NET patients, this can relate directly to patients who have carcinoid heart disease, which is something we always want to evaluate patients for, especially if they've had metastatic disease for a prolonged period of time. And sometimes if they have a bad heart, then it's, we need to basically treat that first before we can consider candidacy for any other kinds of surgery. you then, ask, I think the second part of the question is, can you do surgery for tumors in the peritoneum or the mesentery? So about 20% of patients with gastroenteropancreatic NETs will have peritoneal disease at the time of presentation. And there is really no standard in terms of how to manage these patients. Up until recently, when we didn't have PRT, the thought was that we would treat them surgically if feasible, and systemic therapies don't necessarily work for a majority of these patients. So a lot of it is really dependent on the burden of disease. The way you kind of think of peritoneal disease is it can be disseminated throughout. So if you think of little tiny salt granules that are all through the abdomen, it would be really difficult to clear that disease. However, there are other patients who may have limited disease that's just focused in a few areas that you can clear. So if we can clear the disease, then I think it is favorable to remove, because we do think that there is a survival benefit. Most of the data for peritoneal disease and surgery comes from data that we've basically extrapolated from other metastatic sites like the liver, because this is just a small subset of patients, and frequently there's more disease than can be surgically cleared. And then with respect to the mesentery, especially in small bowel neuroendocrine tumors, a lot of these patients will have nodal metastases within the mesentery that will present as big, bulky tumors that can surround important vessels. A lot of times these can actually be removed with careful planning and preoperative imaging. The times that it can't is when really the nodal metastasis is invading the main trunk or the main feeding vessel that's feeding or taking blood back from the entire small intestine. So if you think of the main trunk of a tree, if that's involved, then sometimes that patient may not be a surgical candidate. And then I think Dr. Anaya and Dr. Clarke alluded to this previously. What is the goal of surgery? Sometimes that also comes into surgical candidacy. So multiple different components to think of when determining.
Yeah, lots to think of. Dr. Clarke, what are your thoughts?
I mean, I think Dr. Gangi said that quite nicely. I think a couple of things. Sometimes I have to explain to patients when they're very disappointed if we can't offer surgery or we are not offering surgery right now. They can be very disappointed and a little maybe even depressed, sad, and they feel like it's a death sentence, and it really isn't. And I really try to emphasize what the role of surgery in disseminated neuroendocrine tumor is. It really is very rarely an opportunity to cure when you have multiple lesions throughout the liver or throughout the peritoneum. What we're trying to do is extend life, and by doing that in sequence with other therapies, we may actually be able to extend life and quality of life for a much longer period. And so sometimes the answer of not surgery right now is actually not a bad thing, and it doesn't necessarily mean that surgery is off the table forever. And then the last thing I'll say is I also see some patients who were told that they're not surgical candidates and they actually are. I would just emphasize, having an expert like Dr. Gangi or Dr. Anaya evaluate their scans, people that do neuroendocrine surgeries quite often, so that you get a fair assessment.
Yeah, thank you. It's important to see a NET expert for sure. Dr. Anaya, what would you have to add?
I think it's all, the majority is being said. I think I love the point that Dr. Clarke mentions about making sure that the case is reviewed by people that do this day in and day out. And I think Dr. Gangi mentioned the importance of planning and really having a thoughtful decision on doing these operations, because they're not all the time easy, and oftentimes they're actually very complex operations, and being able to plan and review ahead of time and not be in a situation where you're having to try to take a tumor emergently or something like that really goes a long way. And the key to to avoid those circumstances is really to get in the hands of people that are experts from a multidisciplinary perspective and that really understand the goals and what the patient is going to gain out of each operation.
Thank you. Some really good points here. So Dr. Anaya, Dr. Gangi mentioned the different sizes tumors. What is considered a small, medium, or large tumor, and how do you determine tumor burden?
Yeah, I think this is a great question, and to some extent this is applicable to all cancers, right? Once we have somebody with a diagnosis of cancer, the next step that we always do is stage the cancer. And what that means is really determine how advanced the cancer is, either locally, where the cancer started, or what we call regionally, which is typically around the lymph nodes of that organ, or distant metastasis, that has the tumor spread elsewhere. And I think this all really speaks to burden of disease and stage of disease and presentation, which is very important because it really helps us have a discussion about prognosis, about types of treatments, and about what the goals of each type of treatment, surgery, or other is for that specific circumstance. The first part of the question, what's small, what's medium, what's large, I think it's a little bit more relative, and it's really more applicable as I think we have mentioned before. There's many different sites where these tumors can originate from, different organs in the body, and in some circumstances, size is very important, particularly for small tumors, because in those circumstances, we know that those small tumors, for example, pancreatic neuroendocrine tumors that are really small, we are able to many times just observe and not have to do any treatment, either surgical or not. Same, maybe the guidance of the type of operation for appendiceal tumors, depending on the size as well. But once the tumor leaves, regardless of where they're located, once the tumor leaves the organ and goes to the lymph nodes or to distant sites like the liver or other places, I think what you have to determine is the burden of that metastatic disease. And there's different ways of doing that. Usually we use a combination of axial images like CT scans most commonly, or MRIs. And we combine that with what we call functional images, which is typically a PET scan that is specific for neuroendocrine tumors that helps us identify areas of cancer that may not be as obvious in other tests. So that's kind of how we determine, and that's the purpose of that. A very important point, I think, to really understand that patients should have the diagnosis, and then they should ask, what's my stage and how does that change things?
Thank you. Dr. Clarke, how would you explain this to a patient?
I mean, I think quite similarly, I think size matters only in terms of location. I think probably some of the smaller tumors that are quite challenging are ones that are in the small bowel. These can be so tiny that you can't actually see the primary tumor where it all started. They can be a centimeter or even less in size, but they, metastasize quite frequently. And so what you'll often see is a lymph node or the liver metastases, and then there's a question of where did the primary tumor actually start, because they can't see it. So I think size is really less critical in those settings, and we really rely on overall tumor burden and our ability to really clear all of the tumor. And I think the comment about imaging, and especially functional imaging in these patients, like a dotatate scan, can be very helpful preoperatively to ensure that we have a really good assessment of where there's active disease.
Thank you. Dr. Gangi, do you have anything to add?
No, I think I have the good fortune of having brilliant colleagues who have, said everything there is to be said. I think size really only matters for pancreatic neuroendocrine tumors and really nowhere else. So I think that's already been mentioned.
Okay. And so, Dr. Clarke, when there is metastatic disease, when it has spread, what is the role of removing only the primary tumor?
This is a very nuanced question. And I think the first point I need to emphasize is really this decision cannot be made outside of a multidisciplinary conversation. So everyone that treats this disease really needs to weigh in on when to operate on these patients. Probably the most frequent scenario in which I either wish people had seen surgeons sooner for resection of the primary tumor, especially in the metastatic setting, is for patients with small bowel neuroendocrine tumors that can really become symptomatic quite quickly and easily, and we can almost predict which tumors will misbehave based on some critical imaging findings. It's a lot easier to manage these tumors in a non-emergent fashion. If there's evidence of mesenteric compromise, which means that the blood supply basically to the intestine is compromised by the tumor. If the patient clinically is already having issues, abdominal pain or cramping, signs of impending obstruction or a food, those are some things that can clue us into the fact that the primary tumor is really about to do something it's not supposed to do. It's really about to misbehave. And that if we can manage that in a timely fashion before it becomes an emergent problem, then that's overall better for the patients. So that's one scenario, but there's so many others. I think primary tumors that are symptomatic, whenever they can be removed, should be removed in the setting of metastatic disease. Other things like tumor grade play a major role in this. So for high-grade tumors, where systemic treatment is really the best option for extending disease, I really try to limit surgery to people that have had either a prolonged course and at least some good response to systemic therapy before we do any surgical intervention. And then, I'll sort of let my colleagues weigh in, but there's a lot of debate, even in patients that are asymptomatic, about whether or not we can improve overall survival by removing the primary tumor, especially in patients that have pancreatic neuroendocrine tumors. I think that's still quite a spirited discussion at our meetings. The timing of when we should do that and how we should do that and which patients we should do that in is still sort of up for debate.
Thank you. Dr. Gangi?
Yeah, I think there is no perfect one-size-fits-all answer for this question. And I think also keep in mind that we're GI surgeons, so we're talking about primarily pancreatic and small bowel neuroendocrine tumors. I think certainly for patients who are symptomatic from their small bowel tumor, there's no question that those lesions should be removed if feasible. With respect to the pancreas, it becomes a little bit more challenging, as Dr. Clarke mentioned, depending on the burden of metastatic disease. And one other consideration is sometimes if the tumor's in the head of the pancreas and the patient has a high liver disease burden, then the concern is sometimes it may actually preclude them from getting additional liver-directed therapies because the risk of infection can be so much higher given the anastomosis that we have to create between the biliary tree and the intestine. So that's one consideration when looking at pancreas tumors specifically. We have looked at some of our own data, and big retrospective studies have suggested that there's probably an overall survival benefit both for pancreas and small bowel nets who have their primary removed. But again, what we have to keep in mind is there's probably a lot of bias in terms of the patients who are getting selected to go to surgery. So as Dr. Clarke mentioned, this is a spirited discussion. The timing of surgery is certainly important, and the option for additional therapies, or if the patient has had any additional therapies, if something is progressing versus not. These are all critical components, and I think she highlighted that this needs to be done in a multidisciplinary setting to make sure that we've basically evaluated all the other options that the patient may have.
Thank you. Dr. Anaya?
No, I think I agree with everything. I think just emphasize what both Dr. Gangi and Dr. Clarke have mentioned about the fact that this is really an individualized decision. I think depending on what the goal of the surgery is, there's so many factors and so many variables. Where's the primary tumor in the pancreas, small bowel, duodenum, stomach, what's the grade, what's the stage, what's the location of the tumor specifically, is the patient symptomatic or not, are there hormonal, functional symptoms as well. So there's many things that we can't really summarize in one. I think some of my good examples were highlighted, but I think we really need to individualize this on a patient-by-patient basis, and in the setting of a tumor board and a multidisciplinary setting is really the best way to do it. Always focused on what are we trying to accomplish and what are the different competing options and what's the best option for this specific patient at this specific time.
Yeah, personalized approach. So Dr. Gangi, here's another question. If the tumor has spread with metastatic disease, what is the role of removing only the liver tumors?
I think individualized approach for patients and the need for multidisciplinary discussion. But generally, when patients have other sites of disease that are not resectable, be it their primary site or additional sources of metastatic disease, we still will consider surgery for liver tumors. And again, that is dependent on is something growing? Have they failed other therapies? But you have to consider that with respect to the liver tumors, there are other options additional to systemic therapy, which our medical oncology colleagues can comment on, and systemic therapy with PRT, which is our nuclear medicine colleagues comment on. But there's also liver-directed therapies with embolization, radioembo, just planned embolization, and chemoembolization. So considering whether someone should have their liver tumors resected in the setting of metastatic disease, we want to know the burden of disease and what the benefit of surgery would be. And a majority of these patients, when I'm talking to them, I tell them that even if we do essentially cytoreductive surgery of your liver, the risk of recurrence in 5 years is over 80%. So this is just potentially buying us some time and resetting the clock. What is the importance of the 70 and 90% cutoffs? essentially, it was really in the 1970s when we first established that patients who had liver metastases from neuroendocrine tumors benefited symptomatically when at least 95% of their liver disease was resected. We saw that their carcinoid symptoms improved. And then this was reevaluated over the next 10 to 20 years. And in the early 2000s, essentially, we started to look at different thresholds, suggesting that, is it okay if we do anything less than 90%? If we look at patients and we cytoreduce them to 70% to 89%, is the benefit just as good as cytoreducing to 90 to 100%? And what we found was that the survival benefit was still there if you were able to reduce at least 70% of the disease in the liver. And the progression-free survival, meaning the duration of time that it took for the disease to recur, was similar among those patients. And then for symptom control, there was also no significant difference between patients who had 70% debulking versus 90 versus 100. And then it was a little bit later from Iowa, I believe, that they looked at the data of cytoreducing less than 70% versus 70 and 90, and found that if you did less than a 70% cytoreduction, there was actually worse overall survival in those cohort of patients, which is why we've kind of stuck with that 70% threshold. So that's where all of that has come from.
Yeah, thanks for sharing that data. Dr. Clarke, do you have anything to add to this?
No, I think that was really nicely summed up. I think in this setting, we're really talking about symptomatic relief for patients. And then I think sequencing other therapies to sort of manage both symptoms, quality of life, and survival for our patients. And I think in this setting, if we can debulk patients, we can buy time and we can buy more therapies or other lines of therapies that we can use later on down the road. I mean, I think that's really the biggest benefit from this.
Thank you. Dr. Anaya, what, if anything, would you like to add?
No, I think they made it very, very clear. I think Dr. Clarke and Dr. Gangi presented all the clear indications of when we consider this and why we have some thresholds and everything. So nothing really to add.
Thank you. We'll end with this last question, starting with Dr. Anaya. What is one thing you would want NET patients to know before they walk in the door to see you? And what's one thing you would want them to leave with?
Usually, we actually talk to our patients before they come to see me or to see our team. We reach out and we try to have them understand that this is going to be a whole journey that requires an individualized approach. So I think that is very important that they understand that this is not, particularly neuroendocrine tumors, there's different goals and there's so many variables that weigh into what treatment is the best treatment for that given patient. So I think before they come in, we make it very clear that we're going to use all of our resources, our multidisciplinary team, multiple discussions through tumor boards and so forth, to really come to the best individualized approach for that patient. And I think after I meet with them, I think probably the one thing that always comes up and I really emphasize to patients, particularly when they present with metastatic disease, is that most of the time, I would say the vast majority of the time, I tell them there's something good and bad about metastatic neuroendocrine tumors. The good is that, patients can live for many, many years, even decades, even with metastatic disease. And this is very in conflict with many other cancers. And the not so good, but I think is more a mindset, is that it becomes more like a chronic disease. So I try to educate them to understand that, if you have diabetes, you can live for many years if it's managed well and appropriately, but you could also die from complication from diabetes if it's not. It's not going to get cured, it's just going to be managed. So I try to emphasize this issue, and that this is when it becomes critical to have a great team that really understands what the best sequence of care, what the best treatment is, one first, the other one second, and really doesn't burn any bridges in what is going to be a long course of a chronic disease.
Yeah, that's encouraging that they can live a long time with it. Dr. Clarke, what would you add?
I think one thing that I'd want NET patients to know when they come in to see us is that surgery is one tool in a bag of tools that we have to treat this disease, and that our goal is really to try to keep patients alive as long as possible and to cure when possible. I think a lot of NET patients come to their initial visits with a fair amount of mistrust of the medical system that's earned. A lot of them have been having symptoms for a long time. They have been misdiagnosed, and you sort of have to go through that grief with them initially, and sort of listen to the negative experiences that they've had before, in order for you to really make progress in your conversation the first time you meet with them. But my hope is, the one thing that they have when they leave is confidence in the team, that the patient really is first, and that what we're trying to do is to really prioritize their needs and their wants, and balance that with managing this very tricky disease. But I do think that patients really need to have confidence in their team and the plan that's been proposed, and it's a two-way conversation. There's a lot of trust that goes into these discussions, but all of that is framed really with the patient at the center.
Thank you for that thoughtful response. Dr. Gangi?
Yeah, so I think by the end of a clinic day, my fellows or residents are tired of me tell patients it's a marathon, not a sprint. So I think that's one thing, is that you're not going to come in and get a simple solution and get to, put this behind you and forget all about it, because that's not what this tumor type allows patients to do. Tell them that they have to like the different members of their team, and I'm just one component of that entire group of people who's going to be taking care of them at different time points. That's especially important, as Dr. Anaya said, for our metastatic patients. But other patients who, present with early disease may ultimately develop metastases later in their course. So I try to make that a point that I want them to understand. And then I think my job is really, I tell them from the get-go, is my job is to kind of help to empower them to understand the disease process and the different treatment options that are available to them, because no two patients really are the same, and then I allude to the fact that this is, zebras, and no two zebras have the same stripes. So although you may hear something worked for another patient with a neuroendocrine tumor, or so-and-so had surgery, or so-and-so had systemic therapy, that might not necessarily apply to you at the particular time point. So those are the things that I either want them to come in understanding, or certainly if they don't understand that when they come in, that's my hope that when they leave, they understand the nuances of the disease process and the management of their tumor type by the NET team.
Thank you so much. Thank you, all three of you, for this very thoughtful, insightful discussion. It's been a pleasure to have a conversation with three incredible NET surgeons, and we hope that it will encourage and empower our NET patient community. And we look forward to the next time that we can discuss again.